السلام عليكم طلابنا. محاضرتنا لهذا اليوم maldevelopment of genital tract by me Dr. Hadil Ali Hamid. Overview. Mullerian ducts form the female reproductive tract. Include fallopian tubes, uterus, cervix, and superior aspect of the vagina. Upper 2/3 of the vagina. All these originate from the Mullerian ducts. Therefore, Mullerian duct anomalies can be present with a wide range of anatomical disruption in any one of these reproductive organs. Mullerian duct anomalies associated with renal and axial skeletal malformation. Why? Because both have the same origin. In the same patient with Mullerian duct anomalies, we will have normal-looking external genitalia and normal functioning ovaries. So she will have a normal secondary sexual characteristic feature. Why? Because the origin of the ovaries and external genitalia is not the same origin of the Mullerian duct. For this reason, it will still normal. Epidemiology. The exact incidence or prevalence of the Mullerian duct anomalies in general population is unknown, but the estimated range ranging between 0.1% to 3.5%. Other studies say the estimated incidence 4.3%. Pathogenesis. It is important to know what behind these anomalies. It is believed that it is a result from disruption in the normal development of Mullerian ducts in the female. At the age of 6 weeks of fetal development, the fetus will have both Mullerian ducts and Wolffian ducts. So at this stage, both ducts will be present. But if the sex of the fetus is female, the Wolffian ducts undergo degeneration and Mullerian duct will be differentiated. Vice versa, if the sex of the fetus is male, the Wolffian duct will be differentiated and the Mullerian duct will be degenerated. Disruption of differentiation will lead to the defect called Mullerian duct anomalies. طلاب بهاي النقطة أريدكم تركزون بالشرح اللي حأقوله. ليش هذا الفيميل أو هاي الفيميل حيكون عندها Mullerian والميل يكون عنده Wolffian. At the time of fertilization, the sex of the fetus will be determined. XX will lead to the female, XY will lead to the male. So, if the sex was male, XY, on the short arm of the chromosome Y, there will be what is known as Sarai gene. This gene is responsible for formation of the testes. In the testes, we will have two types of the cells, Sertoli cells and Leydig cells. The Sertoli cells contain and produce a glycoprotein called Mullerian inhibitory factor. This factor is responsible for inhibition and degeneration of the Mullerian duct. So in the male, because of the presence of the Mullerian inhibitory factor, so there will be differentiation of the Wolffian and degeneration of the Mullerian. بسبب وجود هذا العامل بالميل راح يصير إضمحلال للموليريان وتطور للولفيان. In the female fetus, there is no Y chromosome. There is no testis, there is no Mullerian inhibitory factor. So this will lead to the differentiation of the Mullerian and degeneration of the Wolffian. This is a simple way. Female reproductive tract, for complete development, need to complete 3 phases. What are these 3 phases? Organogenesis, effusion, and septal resorption. Organogenesis, what we mean by it? For normal development, we need normal development of both Mullerian ducts. So if one of these ducts or both of them failed to develop, it will lead to the anomalies. If both of them will lead to what is known as uterine agenesis or hypoplasia. If only one of them, unilateral failure of development, will lead to what is known as unicornuate uterus. Effusion. After development of the Mullerian ducts of the both sides, we will need to fuse the lower segments of both ducts. This effusion in its lower segment will form uterus, cervix, and upper two-thirds of the vagina. Failure of fusion at all will lead to what is known as didelphous uterus. If fusion occurs but incomplete will lead to what is known as bicornuate uterus. Bicornuate الرحم ذو القرنين. didelphous uterus يعني رحمين راح يكون عند هاي المريضة. The term vertical fusion occasionally is used to refer to fusion of ascending sinovaginal bulb with descending Mullerian system. This fusion will lead to the formation of the complete vagina. So, complete vertical fusion will lead to the patent vagina. Incomplete vertical fusion will lead to the imperforated hymen. طلابنا ركزوا لي. The vagina formed by two parts. Upper two-thirds originate from the Mullerian duct. Lower third originate from sinovaginal bulb اللي الأوريجين مالتها من الurogenital sinus. So the vagina has two different origins. In order to form a patent vagina, we need a fusion with canalization of these two parts. الupper اللي مصدره من الموليريان والlower اللي مصدره من السinovaginal bulb. After fusion between two Mullerian ducts, we will have the formation of the septal or longitudinal septum. For normal cavitation of the uterus and normal cervical canal, this septum should be resorbed. Failure of resorption of this septum will lead to the formation of the septate uterus, and this septate uterus either complete or partial. إذن يجب بعد حصول عملية الالتحام بين القناتين يجب أن يصير اضمحلال وامتصاص لهذا الحاجز. إذا هذا الحاجز ما تم امتصاصه بهالحالة راح يتكون هذا الحاجز داخل الرحم وهذا نوع من أنواع Mullerian duct anomalies. ملاحظة تذكر الأوفريز والlower third of the vagina from different origin. الأوفريز originate or derived from germ cells that migrate from primitive yolk sac into the mesenchyme of the peritoneal cavity and subsequently develop into ova. The lower third of the vagina developed from the sinovaginal bulb. I will explain on this picture. This is a female fetus at the age of 6 weeks during embryological life. Look at, we have two Mullerian ducts and two Wolffian ducts. And this is the sinovaginal bulb. Fusion of these developed two Mullerian ducts in its lower segment will form uterus, cervix, and upper two-thirds of the vagina, while the upper part will remain free in order to form the fallopian tube. Later on, this septum should be resorbed in order to form the normal cavitated uterus with normal cervical canal and normal upper two-thirds of the vagina. Later on, the upper two-thirds of the vagina will fused with the lower third of the vagina, and then canalization takes place to form patent vagina. By the age of 12 or 13 weeks, the vagina will be like a mass, but at 20 weeks of gestation, canalization will take place. Failure of canalization will lead to the congenital anomalies of the vagina. Look at, students, the Wolffian duct degenerated and development of the Mullerian duct. Classification of the Mullerian duct anomalies. We have many classes, but the mostly accepted recent one is the classification done by American Fertility Society in correlation with ISHRI. ISHRI, European Society of Human Reproductive and Embryology. No need to mention this. Only I need from you to know the new classification. مو بالضرورة إنه تحفظون هاي المصطلحات، فقط تعرفون التقسيم الجديد. Class 1, agenesis and hypoplasia may include the cervix, the vagina, fundus, or tube. One of the most important congenital anomalies in the Class 1 is Mayer-Rokitansky-Koster-Hauser syndrome. It is the most common one and second most important cause for primary amenorrhea. This type of syndrome include complete agenesis or underdeveloped uterus. يعني أما اليوترس ما موجود بالأصل أو يكون underdeveloped يكون طفولي أو يسموه infantile uterus. Mayer-Rokitansky-Kuster-Hauser syndrome is a disorder occur in the female. This condition characterized by absence of the vagina, absence of uterus, and absence of the cervix, or underdeveloped. We have a many range of this type of anomaly. Include absence of the vagina with the presence of the midline uterus. I will take it in details later on. Mayer-Rokitansky syndrome characterized by patient presented by the age of 16 years old in the form of the primary amenorrhea. The chromosomal pattern will be normal, 46XX, with normal functioning ovaries, normal secondary sexual characteristic features, normal breast and pubic hair. This female unable to get pregnant, so need assisted reproductive technique, التقنيات المساعدة على الإنجاب، وسوف يتم شرحها فيما بعد. This picture showed you that this is type of Mayer-Rokitansky-Kuster-Hauser syndrome. The normal functioning ovaries with Mullerian remnant. It is rudimentary. There is no uterus, no cervix, and no upper 2/3 of the vagina. But the lower 1/3 appear in the form of the vaginal dimple, can be seen during examination. This is obliteration of the vagina. Class 2, it is called unicornuate uterus أو الرحم الوحيد القرن. This type of Mullerian duct anomaly occurs when failure of Mullerian duct to migrate to its correct place and failure in unilateral development occur. You know, we need the development of both Mullerian duct. So if one of them failed to develop with development of the contralateral side, this will lead to the formation of unicornuate uterus. Unicornuate uterus, it is either with horn or without horn. I will explain it on this picture. This is the unicornuate uterus. This is the normal uterus. One side will develop with failure of development of the other side. So we will have single uterine cavity, single fallopian tube, single ovary. This is with no horn, but here we have a remnant part of the contralateral side in the form of rudimentary horn. This horn of many types. It is either communicating or non-communicating, cavitated or non-cavitated. This type is the worst type. This is, and this type we will have no severe clinical manifestation. This type is connected, so, and cavitated. What we mean by cavitated? Cavitated mean presence of endometrium, undergo a hormonal effect, lead to the menstruation and menstrual shedding. This shedding need outflow. So outflow will occur normally into the original uterus. This type, there is no endometrium, so no menstruation, no shedding, no problem. But this type, there will be a menstruation, there will be shedding, but no outflow. For this reason, collection of the blood in this horn will lead to the patient suffering from the abdominal pain, pelvic pain, backache, and even abdominal distension. And sometimes it's severe enough to lead to the rupture of this horn and the patient presented in a shock state with acute abdomen. And the clinical presentation similar to the ectopic pregnancy, الحمل خارج الرحم. The prognosis, but reproductive prognosis, because it will lead to the miscarriage, intrauterine growth restriction, and the premature birth. It accounts to 0.3 to 4% of uterine anomalies. Class 3, uterus didelphus, occur when there is complete failure of approximation and diffusion of Mullerian duct. So we will have 2 uterine cavities, 2 cervices, 2 vaginas separated by longitudinal septum, but with normal menstrual flow. This septum may be oblique, so there will be obstruction in one vagina. So obstruction to the menstrual flow lead to the retention, and this will lead to the hematoculpus, hematometra, hematosalpinx. And the patient presented with pelvic pain, lumbar pain, vaginal discomfort due to collection of the blood. It represents 3 to 4% of Mullerian malformations. Regarding to the prognosis, it is good. There is a case reported that pregnancy with a twin occur in development of the fetuses in each of uterine cavity. Uterus didelphus سببه complete failure of fusion. ما راح يصير أي التحام بين القنوات، فكل قناة راح تتطور وتكون لنا genital tract بحد ذاتها. فلهذا المرضى حيكون عندهم رحمين، عنقين رحم، وأيضا مهبلين. لكن ممكن يكون عندنا 2 uterine cavities, 2 cervices with single vagina. ووضحنا السبتم أما تكون longitudinal أو تكون oblique. إذا كانت longitudinal ماكو أي مشكلة لأنه حيكون normal menstrual flow، ولكن إذا كانت oblique راح يصير تجمع للدم وراح يصير عندنا obstruction. راح أوضحها على الصورة. This is the normal uterus, and this is the uterine didelphus. 2 uterine cavity, 2 cervices, but single vagina. This picture shows 2 uterine cavities, 2 cervices with longitudinal septum between 2 vaginas with normal menstrual flow. In this picture, we have an oblique septum. This oblique septum will cause obstructed hemiuterus. This is called obstructed hemiuterus, and this is unobstructed hemiuterus. This obstruction will lead to the collection of the blood in the vagina called hematoculpus, collection of the blood in the uterus called hematometra, collection of the blood in the fallopian tube called hematosalpinx. This is a flow, it is called retrograde, يعني الاتجاه العكسي. So this blood might enter to the peritoneal cavity, lead to the peritoneal bleeding and acute abdomen. This is the worst type. Class 4, bicornuate uterus. It is failure of fusion but incomplete, result in formation of 2 uterine cavities and 1 cervix, 1 vagina. The bicornuate uterus, it represents a 10% of the cases. In majority asymptomatic, but sometimes present with miscarriage or premature birth. This is the normal uterus, and this is the bicornuate uterus. Look at, we have 2 uterine cavities, single cervix, single vagina. Please students, look at to the uterine fundus. It is a hard shape, while normally it is like a dome. We should differentiate this anomaly from the class 5, it is called septate uterus. I will take it. A class 5, septate uterus, it is failure of resorption of the longitudinal septum will lead to the formation of the septate uterus. It is either partial or complete. This septum either muscular or fibrous. It is important to know because it will influence the therapeutic approach. It represents 55% of the malformation. It is associated with recurrent miscarriage and premature birth. This type of anomaly is the worst one. أسوأ الأنواع هو السبتate. Look at this picture. This is the normal uterus and this is the septate uterus. Internally, it looks like the bicornuate uterus. But if we look to the fundus, this is a normal fundus. there is a normal dome, while in this picture, the fundus like a heart shape. This is important to differentiate between septate and bicornuate. Class 6 arcuate uterus. It is also considered a variant of normal, and it is only present due to failure of formation of the normal curvature at the dome, curvature at the fundus. It is of no clinical significance, and we have no any reproductive alteration. It is occur due to failure of final stage of resorption of the intermolarian septum and need no any intervention. Even arcuate uterus, it is a normal variant. Loss of the fundal dome. The fundus will be flat instead of this curvature of this dome. Both of them considered to be normal functioning uterus. There is no any clinical significance. A patient will have normal reproductive life without any complication. It is just a normal variant. تشوه خلقي بس ما مأثر على الوظائف. Class 7, induced by diethylstilbestrol. The shape of the uterus will be T-shaped, detected in the daughters of the women who used the drug during pregnancy. This type of anomaly ranging from T-shaped uterus, hypoplastic uterus, or irregular uterus. Regarding to the prognosis, it is a poor prognosis because poor chance of the pregnancy with high risk of miscarriage and ectopic pregnancy. Diethylstilbestrol discontinued by 1971. So for this reason, it is not increasingly seen nowadays. هذا النوع من أنواع الأدوية كان يؤخذ من قبل الحوامل كنوع من أنواع المثبتات. إلى تأثير يسبب لنا تي شيب يوترس للبيبي اللي راح ينولد وبمشاكل كثيرة. حاليا تم منعه، ولهذا هذا النوع من التشوهات الخلقية لا يشاهد حاليا. This is the T-shaped uterus. This table showed you the classes, and this is picture show the different anomalies concomitantly. What about the clinical presentation? Amenorrhea, primary amenorrhea. By the age of 16 years old, the patient failed to menstruate because of outflow obstruction. May be presented in the form of the pelvic pain, infertility, recurrent miscarriage, preterm labor, difficulty in insertion of the tampon, or difficulty during the intercourse. Diagnostic workup. The gynecologists first need to have full detailed history and examination, including the general examination, abdominal examination, pelvic examination, examination of the external genitalia, and even internal female organs should be reviewed. Next, imaging studies. We have pelvic ultrasound, either two-dimensional or three-dimensional. The three-dimensional, it is superior than the two-dimensional for diagnosis of the Mullerian duct anomalies. Pelvic MRI, it is the gold standard for the diagnosis of Mullerian duct anomalies. It is important for localization of the kidneys and for detection of presence or absence of the uterus and the cervix. Hysterosalpingography. This type of imaging study used by injecting a dye through the cervix to fill the cervix, uterus, and fallopian tube, and then imaging by X-ray. This will lead to the visualization of the female genital tract and determination of any anomaly. Hysteroscopy, it is a telescope of the uterus, introduced through vagina and cervix to visualize the cervix and the uterus. It enables us to have a direct vision. Vaginoscopy, it is a telescope of the vagina, enabled to see any anomalies of the vagina. Laparoscopy, it is a tube inserted into the abdomen with the presence of the camera to view the abdominal and pelvic cavity. We need also lab investigations. It is a hormonal study, FSH, LH, testosterone, All these normal. Why? Because we have normal functioning ovaries. Mullerian duct anomalies, important to have a chromosomal studies to differentiate between Mayer-Rokitansky-Koster-Hauser syndrome and androgen insensitivity syndrome. I will explain it later on. This picture hysterosalpingography. الصور هاي للطلع حتى تفهمون شنو معنى hysterosalpingography. هاي الصورة توضح لنا نوع من أنواع التشوهات الخلقية. heart shape uterus. هاي الصورة ممكن نشوفها بالseptate uterus وبالbicornuate uterus. إذن we cannot differentiate by hysterosalpingography, but we can differentiate between them by MRI. فقط للطلع طلاب. This is a bicornuate uterus. By MRI, we see the heart-shaped fundus, while this septate uterus, normal uterine fundus. Preservation of dome. There is no indentation. هاي الخسفة الموجودة هنا واللي تسبب الهارت شيب يوترس ما موجودة هنا. فهذا فقط للتمييز بين الاثنين. Treatment. Treatment of the Mullerian duct anomalies according to the class. Class 1, as we remember, it is agenesis or hypoplasia. So the treatment of choice is by creation of functioning new vagina. For reproduction, this is done by assisted reproductive technique. Class 1 will be explained in details in the congenital anomalies of the vagina. Isolated vaginal agenesis also will be explained. Class 2, surgical treatment should be reserved for the patient with rudimentary horn. So, the unicornuate uterus by itself, if without any clinical manifestation with the patient has a normal reproductive life, need no intervention. But when we have a rudimentary horn, which type of this horn? Functioning non-communicated. This is the most dangerous one because it will lead to the endanger the life of the female. So this done by either laparoscopic excision and lead to the excellent result, or surgical intervention with bipolar coagulation of the pedicle. Also, we will have a very excellent result. Class 3. The class 3 is uterine didelphus. Surgical intervention, depending on whatever, the obstructed or non-obstructed. Regarding to the non-obstructed, if the patient has no any complication, leave it without a treatment. But if the patient has a complication in reproduction like recurrent miscarriage or preterm labor, so need a surgery. It is called trans-mans meteroplasty, عملية تجميلية للرحم, by which the uterine cavities will be unified to one uterine cavity. إذن عملية توحيد الرحمين إلى رحم واحد حتى يستوعب الحمل وما تصير للمريضة مشاكل. The obstructed type, because of the presence of the oblique septum and collection of the blood, so excision of the septum is important. In addition to that, hysterectomy, hysterectomy only for obstructed side, removal of the fallopian tube and ovary. إذن النوع الobstructed راح نرفع السبتم ونرفع الرحم اللي مسبب المشكلة ونرفع ويا قناة البيض ونرفع ويا المبيض ونبقي الجهة الثانية النون obstructed حتكون functioning وتكمل الريبرودكتيف لايف مالت المريضة normally. Class 4, bicornuate uterus. It is not a cause for difficulty in conception, but sometimes patient presented with recurrent miscarriage, second trimester miscarriage, and premature birth. In this condition, we need intervention, and this is done by trans-mans meteroplasty. Good result, 90% will have a full pregnancy. Class 5, septate uterus. It is the worst type with poor prognosis associated with recurrent miscarriage, preterm labor, and difficulty in conception. For this reason, need surgical intervention عن طريق الهيستروسكوبي. Hysteroscopy meteroplasty to remove this septa. The result will be good. Class 7, it depends on type of anomalies. If it is severely anomalized or underdeveloped or severely irregular, in this condition, the patient, if need to have a normal reproductive life and need to become a mother, need assisted reproductive technique. التقنيات المساعدة على الإنجاب. هذا لأي female تعاني من رحم طفولي نحتاج surrogate mother. شو نقصد بالسيروجيت؟ الأم الحاضنة أو الأم البديلة. يتم حقن الجنين اللي ينأخذ من الفيميل اللي تعاني من التشوهات الخلقية لأن هي عندها مبايض طبيعية، فناخذ منها البويضة مع الحيمن مال زوجها ويتم عملية الفرتلايزيشن ان فيترو يعني خارج الجسم، وبعدها يتم حقن هذا الجنين في الأم الحاضنة. Congenital anomalies of the vagina.